Hello. For our group project, we decided to do pediatric asthma, and we are going to be teaching the class about this disorder. In our group is Monique Boyd, Rebecca Wesson, Janet Vang, Yalitza Valdovinos, Harmanchit Chohan, and Lovedeep Singh.
Diagnosis. Pediatric asthma is diagnosed based on recurrent symptoms such as wheezing, coughing, especially at night or early morning, shortness of breath, and chest tightness. Symptoms are episodic, vary over time, and often triggered by exercise, viral infections, allergens, or cold air. Improvement with bronchodilator treatment supports the diagnosis. A personal or family history of asthma or allergies is common. Physical exam may show expiratory wheezing, though it can be normal between episodes. In children's 5 and under, spirometry shows reversible airflow obstruction. In younger children, diagnosis is clinical. Other causes of wheezing should be ruled out. Pathophysiology. Asthma in children is caused by chronic inflammation of the airways. When exposed to triggers such as allergies, viral infections, exercise, or cold air, the airways become swollen, produce more mucus, and tighten due to smooth muscle contractions. This narrows the airways and makes it difficult for air to move in and out, causing wheezing, coughing, and shortness of breath. These changes are usually reversible with asthma medications.
Risk factors. Pediatric asthma risk is increased by family history of asthma or allergies, early allergic conditions like eczema and exposure to tobacco smoke or air pollution, prematurity, low birth weight, and viral respiratory infections in early childhood also raise risk. Living in crowded or urban environments, limited access to healthcare and obesity can further contribute to developing asthma. Expected findings. Children with asthma commonly have recurrent wheezing, coughing, shortness of breath, and chest tightness. Symptoms are often triggered by viral infections, allergens, cold air, or activity and may improve with bronchodilators. On exam, wheezing, prolonged expiration, and signs of increased work of breathing may be present, while pulmonary function testing can show reversible airflow obstruction in older children.
For lab tests and diagnostic procedures, pulmonary function tests, spirometry is typically used in children 5 to 6 years and older because it requires cooperation. And improvement after a bronchodilator helps confirm asthma and assess severity. For peak expiratory flow rate, it's especially helpful in school-aged children for daily monitoring. It allows families to recognize early airway narrowing before symptoms worsen and is commonly used in asthma action plans. Pulse oximetry. During acute asthma exacerbations, pulse oximetry helps assess oxygen saturation. Levels below 95% may indicate worsening respiratory status and the need for supplemental oxygen or escalation of care. And allergy testing may be indicated in children with persistent or poorly controlled asthma. Identifying triggers such as pollen, dust mites, or pet dander helps guide environmental control and long-term management. Status asthmaticus is a life-threatening asthma exacerbation that does not respond to initial bronchodilator therapy and often requires continuous treatment and possible ICU care. Respiratory distress or failure is a severe airway obstruction that increases work of breathing and may progress to respiratory failure if the child becomes fatigued. Hypoxemia Airway inflammation and mucus plugging impair gas exchange, leading to decreased oxygen saturation during exacerbations, delayed growth. Poorly controlled asthma and long-term steroid use can negatively impact growth in pediatric patients, and frequent hospitalizations. Recurrent exacerbations lead to repeated hospital admissions and disruptions in normal growth, development, and school attendance.
Some therapeutic procedures are oxygen therapy, nebulized bronchodilator treatments, and mechanical ventilation. In oxygen therapy, it is used for acute exacerbations and it maintains adequate oxygen saturations. The nebulized bronchodilator treatments, they're used for rapid delivery of medications during attacks and commonly are albuterol ipratropium. And mechanical ventilation, they're reserved for severe and life-threatening cases, and it is used when respiratory failure is present. Medications. So the there are like 4,000 medications that are used for the attacks. First is short-acting beta agonists, SABA, and they're used for quick relief of acute symptoms. They relaxes bronchial smooth muscle, and example of it is albuterol. And then we have inhaled corticosteroids, ICS. They're used for long-term control. They reduce inflammation, and some examples are fluticasone and budesonide. And then we have glucotrine modifiers. They're oral medications for maintaining therapy, and they're helpful for allergic or exercise-induced asthma. Example is montelukast. And then we have systemic corticosteroids. They're used for severe exacerbations or acute attacks. They're only short-term use, and some examples are prednisone and methylprednisolone.
This slide covers nursing management during an asthma exacerbation. We start by the patient's breathing, including respiratory effort and oxygen levels. Medications are given as prescribed, and we monitor closely to see if there's improvement. Keeping the patient upright helps promote lung expansion. We also encourage proper airway clearance techniques like coughing and correct inhaler and nebulizer use. Finally, patient and family education is important so they understand trigger, action plan, and when to seek medical attention. This slide highlights the interprofessional team involved in managing asthma. The pediatrician diagnoses and prescribes medications. A pulmonologist may be involved if the asthma is severe or difficult to control. Respiratory therapists help with breathing treatments and oxygen support. Allergists work to identify and manage triggers, and the school nurse also plays an important role in supporting asthma care during school hours.
So for the health promotion and disease prevention, the first one is to keep a home clean and dust-free. Stay physical active with the proper asthma control and pre-exercise inhaler use if ordered. Avoid close contact with the people who are sick. Always carry a rescue inhaler. Take a control medication such as inhaled corticosteroids every day, even when feeling well. Use a spacer with inhaler if prescribed to improve medication delivery. Rinse mouth after steroid inhaler use to prevent oral thrust. And clean education is stay away from the smoke, vaping, and strong odor. After inhaling the medication, hold your breath for a slow count of 10. This allows the particles to settle into the air sacs rather than being inhaled immediately. Avoid strong perfumes, scent, candles, harsh cleaning chemicals like bleach, which can irritate sensitive airway. Seek a medical care if symptoms worse, the rescue inhaler does not help, or breathing become difficult. And here's our reference page, and we all done. Thank you so much.